thought I would do respiratory acidosis and respiratory alkalosis. Talking about respiratory acidosis. Respiratory acidosis refers to the total concentration of buffer base that's lower than normal with a relative increase in hydrogen concentrations. Thus, a greater number of hydrogen ions are circulating in the blood that more than can be absorbed by the buffer system. In other words, simply put, the patient's not breathing fast enough or well enough to expel the CO2. This CO2 combines with the hydrogen atoms and creates carbonic acid, which causes acidosis. Respiratory alkalosis, on the other hand, refers to a deficit of carbonic acid and a decrease in hydrogen ion concentration that results from accumulation of base or from the loss of acid without a comparable loss of base in the body fluids. Or, in other words, to put it simply, there is not enough CO2 in the system to combine with the hydrogen atoms to create carbonic acid, which causes alkalosis, respiratory alkalosis. So, if we have either one, too high of hydrogen atoms, too high in carbon dioxide creates carbonic acid, putting your patient into respiratory acidosis. If you have a decrease in carbon dioxide and hydrogen atoms, therefore the base, the bicarbonate HCO3, can take over and cause respiratory alkalosis. Normal ABG values, the pH is 7.35 to 7.45. The PaCO2 or the PCO2, 35 to 45, and the bicarbonate or HCO3 is 21 to 28. The main diagnostic test we're going to be on alert for, either for an order or the results, is an ABG, arterial blood gas. We are also going to monitor their potassium level. Depending on the underlying condition, a diagnostic test may be a sputum culture, a chest X-ray, a CBC, and an electrolyte panel. The Glasgow coma scale to determine the consciousness level might need to be done. As you can see from this slide, our respiratory system is not only just the lungs. It happens to be your nasal cavity, your throat, the bronchi, the right and left lung, and the diaphragm. The alveolar surfaces are where gas exchange takes place. I think of those alveoli, looks like little bunches of grapes. And on the entire surface of the inside of these alveoli is where your gas exchange takes place. Oxygen comes in and CO2 goes out. Okay, so let's talk about some causes. Respiratory acidosis is caused by primary defects in the function of the lungs or changes in normal respiratory patterns. Any condition that causes an obstruction of the airway leading to hypoventilation or depresses the respiratory system can cause respiratory acidosis. Some of those conditions would be central nervous system depression, like you would see in an opioid overdose or a heroin overdose. In those cases, that is an emergent situation and we're going to give them some Narcan. Narcan only lasts about 5 minutes, so we may have to do more than one dose. Neuromuscular disease, like muscular dystrophy, or what if they've had a stroke? What if they have Lou Gehrig's disease, MS? Chronic obstructive lung disease, which is COPD, emphysema. Thoracic cage abnormalities like kyphosis, scoliosis, obesity-related hypoventilation syndrome, and hypothyroidism. Now, the thoracic cage abnormalities, if they have chronic COPD or emphysema, their abnormality may appear to be a barrel chest. That's because the lungs are trying to expand. So if that is hindered, the expansion is hindered by a neuromuscular disease as well, or a stroke, that's where we would get the respiratory acidosis. Respiratory alkalosis, on the other hand, results from conditions that cause an overstimulation of the respiratory system, such as anxiety or pain, sepsis, central nervous stimulation, amphetamine or cocaine overdose, aspirin overdose, pregnancy, cirrhosis of the liver, hypoxemia, which could be from a pulmonary embolism or living at high altitudes, or hyperthyroidism. There's very distinct signs and symptoms for respiratory acidosis. In the neurological setting or the neurological assessment, you may see lethargy, confusion, dizziness, headache, or coma. In assessing the cardiovascular system, you may see decreased blood pressure, dysrhythmias related to hyperkalemia from compensation. That's why we would look at the electrolyte panel, such as paying attention to potassium, warm, flushed skin related to peripheral vasodilation. We also, in the neuromuscular area, we would see muscle weakness and seizures. In the respiratory assessment, the respiratory rate and depth increase in an attempt to exhale the acids. However, when there is a respiratory problem and the lungs are unable to compensate, hypoventilation with hypoxia occurs. Now, if you were to assess their gastrointestinal, you would see no significant findings. You may see some select all that apply from the items on this slide. Okay, signs and symptoms of respiratory alkalosis. In the neurological assessment, you may see the patient have dizziness, or they may complain of dizziness and lightheadedness. They may be confused, and they may have a headache. In the cardiovascular assessment, you may find low blood pressure, tachycardia, and some dysrhythmias. In the gastrointestinal assessment, they may complain of nausea, they may have vomiting, they may have diarrhea, and they may complain of epigastric pain. In the neuromuscular assessment, you may see tetany, numbness, tingling of the extremities, hyperreflexia, and seizures. Now, the respiratory system is going to try to compensate with the rate and the depth of the respirations. However, when there is a respiratory problem and the lungs are unable to compensate, hyperventilation may occur. Now, some of the questions you may see on this would be a select all that apply. Or what assessment finding would be significant for a patient who comes in and has respiratory alkalosis signs and symptoms. Let's talk about some interventions and implementation. When you look at a patient, you're going to go, okay, so now we have determined what our patient is experiencing, whether it's respiratory acidosis or respiratory alkalosis. Now, what are we going to do about it? What are we going to do for them? The types of questions you will see will be outcome related or intervention implementation related. Some interventions and implementation that we can do for a respiratory acidotic patient would be to monitor for signs and symptoms of respiratory distress. We are going to administer the O2 as it's prescribed. We are going to place the patient in a semi-Fowler's position. We are going to encourage and assist the client to turn, cough, and deep breathe, because that will get those fluids moving, and those maybe some secretions will be moving to facilitate them either coughing, or that fluid moving will facilitate the gas exchange of O2 and CO2. You're going to prepare to administer breathing treatments as prescribed. You may need to suction the patient's airway if necessary. And you are going to have stuff there to prepare to intubate your patient and put them on a mechanical ventilation system if they are severe acidosis and CO2 retention. Respiratory alkalosis, on the other hand, we're still going to monitor for signs of respiratory distress. We are going to provide emotional support and reassurance if the patient is having anxiety and they have rapid respirations. We're going to encourage appropriate breathing patterns like slow, deep breathing in through their nose and out through their mouth, pursed lip breathing. We're going to assist with breathing techniques and breathing aids if needed and as prescribed, like voluntarily holding their breath, using a rebreather mask, CO2 breaths, which is having them breathe into a brown paper bag. Provide cautious care with ventilator clients so that they are not forced to take breaths too deeply or rapidly. And you're going to prepare to administer calcium gluconate for tetany as prescribed. Like I said, there are many illnesses and comorbidities that these two can occur in. Once you determine their past medical history and what they might be at risk for, you look at their ABGs. The doctor will order an arterial blood gas. You look at their arterial blood gas results, and you can determine whether they are alkalotic or acidotic just by looking at the pH. If you look at the other numbers, the CO2, if it's elevated, then you would say that it's respiratory acidosis. If the pH is high, greater than 7.45, and your CO2 is low, then it would be respiratory alkalosis. I hope this helps. You need to just know the numbers and look at your patients and try to assess them as best as you can. In respiratory acidosis, you may need to use the Glasgow Coma Scale because of the confusion and the lethargy. Thank you.